Well, good afternoon, everyone. Welcome to today's webinar, which is the Recovery Shortcut, How Behavioral Health Claims Can Slash your claim duration. My name is Holly Foxworth. I'm a registered nurse, and I am the Vice President of Marketing and Communications here at Axiom Medical, and I'm thrilled to be your host today. I'm especially excited about this topic in particular because we're going to look at something that really has an enormous impact on what your injury outcome is. And many of those times, it's not something that you can see that's going to show up on a lab test or show up on an x-ray. Many times it's not even included in many of their original treatment plans. So we know that physical recovery matters, but we want to get into what happens when the other things come in, such as fear, anxiety, lack of sleep, all of those things that are associated with that. So that's where our conversation will begin today. We do have a fantastic panel of guests that are joining us. We have Daryl Wheeler, we have Dr. Scott Cherry, we have Jennifer Cox, and we also have Sarah Hathaway, so you'll get to meet them momentarily. But real quick, let's just go over a few quick mentions here as you look at your screen in front of you. One thing I will say is that today we designed this webinar to be extremely interactive. We're going to be playing games. We've got myth versus reality, lots of opportunities for you guys to utilize that chat feature and interact with us directly. So if there's something that you want to share, if there's something that may be going on in your organization, anything you want to share with the other attendees, please make sure to use that chat. And for those of you who regularly attend these events, you know that I like to send out gifts after these events for those that are engaged the most. So participating in those, answering the questions, things like that. So if you'd like gifts, you definitely want to make for sure that you know where that chat box is there and that you're interacting with us. We do have a resource section that's located there at the bottom. And if I'm not mistaken, we also have some NSC free passes down there. So you're welcome to look into those. Today will be a SHRM continuing education session. So you'll be able to get your certificate for that. The only thing that is required before you get that certificate is that you just have to remain with us for the remainder of the hour and then complete the survey that's right there at the end. We'll send out the slides within 24 hours, so don't worry about writing things down or having to screenshot things. We'll make for sure that we get you all of those materials after this in case you want to refer back to them. And then finally, the last thing I wanted to mention was if you'll look at the top right-hand side of your screen, you'll see where the RSVP button is, and that is for our next webinar next month, and that's going to be on fatigue, the impact that fatigue has on injuries. Dr. Cherry, this is one of the sessions that he gives at many of our national shows, and it's excellent, so you definitely don't want to miss that. So with that being said, let's go ahead and meet our panel. Dr. Cherry, let's start with you.
Well, thank you, Holly, and good afternoon, everyone. My name is Scott Cherry. I'm Axiom Medical's Chief Medical Officer. My professional background is I'm board certified in preventive medicine, public health, and occupational environmental medicine. And I've been supporting industry, military, and governmental operations for the past 20 years, and it's a pleasure to be with you.
Awesome. And he'll kill me that I told you this, but it's actually also his birthday today. So happy birthday to Dr. Cherry. We appreciate you being here. Awesome. Dara, how about you?
Yeah, the chat's already blowing up with that, Scott. So
it is. Happy birthday indeed.
Wow.
I like birthdays, so I like embarrassing my colleagues with their birthdays because it's really fun.
It's like 3 this year for me, I think.
Great to see everybody. My name is Dara Wheeler. I've been with Axiom for 20 years, and I've been thinking a lot about the why we're here today, and we love helping people as kind of primary goal number one. And we realized years ago that there's no distinction between physical and mental health in terms of supporting people. And so I'm really excited about this topic. I'm excited to have Sarah and Jennifer here. Sarah, you want to go next?
Mm-hmm. Thanks, Sarah. Hi, I'm Sarah Hathaway. I'm the Director of Behavioral Health and Absence Management here at Axiom. I'm a licensed clinical social worker, and I've spent a little more than a decade in workplace mental health and disability. And so I'm really excited to talk today about how mental health really impacts the work leave, both work-related injuries and personal medical issues, so we can help keep your employees healthy and get them back to work.
Thank you, Sarah. And Jennifer, how about you?
Yes, hello everyone. First of all, I'm delighted to be here, so thank you for the invitation to be a part of the conversation today. My name is Jen Cox, and I am the manager of our National Trainer Network for Mental Health First Aid USA, and we are with the National Council for Mental Wellbeing in Washington, D.C. My background is I'm a licensed creative arts therapist, a learning development professional, and also a certified wellbeing practitioner. So happy to give my insights here in regards to wellness and the workplace and mental health and how we can just build our skills and expand our capacity to be responsive. So happy to be here.
Absolutely. Well, thank all of you for joining us today. I'm really looking forward to this conversation. I'm sure that the audience is as well. But let's go through behavioral health claims and how that kind of drives the costs that are kind of driving those claims. And Sarah, I'll come to you first. When you look at some of these claim outcomes, where do you see that behavioral health is beginning to affect not just the duration, but also the cost of some of these work comp claims?
Yeah, so, just as mental health issues affect us out in the world, they affect us in the workplace too. And so when we have injured workers, of course, a part of that population is going to be dealing with their own mental health issues, whether that's just a high level of stress or a diagnosable mental health condition. We're going to see that in that population as well. And in fact, when it comes to injured workers, while behavioral health claims make up a very small portion of the injured worker population, they actually are one of the most expensive, if not the most expensive, type of injury claim. And even when there's not an actual behavioral health claim, when it's not necessarily tied to the work injury itself, or it's not arising out of work, work comp claims that involve a behavioral health factor, again, even if it's not a diagnosable condition, they're 2.5 times more expensive than your average workers' comp claim. So the expense to a company, to insurers, TPAs, those expenses just skyrocket when there's a behavioral health factor involved. And when it comes to that time out of work, the lost time for those injured workers actually doubles if there is a mental health factor.
Wow. Doubles. That's significant. Dr. Sherry, what would you say that the relationship is then between like chronic pain, when you're looking at depression, you're looking at maybe people that have been put on opioids, they're having some of these prolonged recoveries. What would you say that the relationship between all of that would be?
Yeah, they're highly correlated, and it seems like one feeds into the other. And so if someone already has chronic pain, they're very highly likely to also be depressed, or sometimes it's the chicken or the egg, which came first. People who are depressed may much more likely are experiencing chronic pain, and then when that occurs, the chances of having opiate use as part of the treatment plan dramatically goes up, and there's a huge amount of evidence showing if there's early opioid use in claims, the duration of these claims can dramatically be raised up to 2 to 3 months. And so what we're seeing really is this dramatic headwind for worker injuries where mental health diagnosable conditions or just acute stressors are becoming much more common, and it's affecting personal health as well as workplace health. And as I've been digging into this the last few years, it's very striking that actually the mental health components like fear avoidance, risk, concern for re-injury, things like that are maybe more important than the actual mechanism of injury or the severity of the physical injury.
Absolutely. And Dara, what would you say when we look at it then from an employer perspective? Do organizations, would you say that they fully recognize that these as behavioral health claims as an issue, or do you think that it's something that too often is treated as something that's separate, that's an HR issue, or that's a medical thing that we're not involved in? How do you feel like that's viewed from a perspective of an employer?
I think it's changed a little, but I don't know that it's changed all that much. I think some places, some jurisdictions changed the way that they handled claims for behavioral mental health during COVID, but I still think generally there's a lot of fear and uncertainty within organizations around how to manage through that. And so there's a distinction between it becomes very siloed in the way organizations handle what they think of as physical versus a mental health claim or behavioral health claim, and states have various supportive regulations around that. But I still think it's mostly feared, and the mental health first aid at work that Jennifer's group does on a lot of that side. We've heard more and more employers have interest in that framework and start to implement that kind of framework, but that is a very different. The claims piece is a bit of a different beast.
Yeah, definitely. Even when organizations may understand that behavioral health issues matter, that they impact some of the recoveries, things like that, sometimes knowing what to do about it is a completely different challenge in and of itself. And so I'm actually interested to hear from all of you guys. So remember that part where we talked about the I send gifts at the end, and you write in the chat, this is the section, this is the practice session before we get into the myth versus reality. But I am interested to know from you guys, what does your organization struggle with the most, would you feel, when it comes to behavioral health? Would you say it's recognizing the signs early enough? Would you say that it's maybe equipping your managers to be able to start having some of those conversations with employees that may be impacted? Maybe it's understanding who owns it, like what we talked about in the very beginning, that there's some confusion there, or maybe even connecting some people to the right resources. And if I didn't include yours in this, you're more than happy to write that there in the chat. But definitely I want to hear from you guys what your take is and what you're experiencing in your individual workplaces. Sarah, how do you feel about this? What do you see most common with this?
Well, I see it all across the board with organizations, and oftentimes it's all of it. But I think the biggest barrier is not really understanding mental health well enough. Even in the healthcare system, we haven't done a wonderful job of integrating physical and mental health and just talking about health as a whole. If I'm not physically well, it's going to impact my mental health. If I'm not mentally well, it's impacting my physical health. And it's all one body that's trying to function together, right? And so even in the healthcare system, we haven't done a great job of really tying those together and getting that mentality out there. I think there are providers who are doing that, but kind of as Dara said, in the workplace, what's happening, we still have a long way to go. And so if we as professionals aren't getting that message out there well enough, how are employers supposed to understand it? So if there's a lack of understanding, how do we identify it? Who's identifying it? What do we do when we identify an issue? And so really it's kind of all across the board.
Yeah. I'm loving seeing all of these responses that are coming in. Dennis had talked about equipping the managers, saying that it was easy for the office to see, but with work going on, everyone is so busy. And that's a great point, that everybody's going in their different directions. They may not recognize what actually is occurring there. I love what Debbie put about the legality of asking appropriate questions without pushing the HIPAA limit. That's something that we can definitely get into and kind of talk about where that line is and what you can do even if you're not a healthcare professional, to be able to help some of those employees. I see a lot of you are saying both when it comes to management, but then also some of the communication pieces. So excellent job. It looks like I have a lot of gifts I'm going to be sending out to you guys, but excellent feedback. And we really appreciate seeing these topics and what it is that you're seeing specifically on your end, because that tells us, that gives us an indication on where we need to point our efforts to continue in the education spectrum there. Let's see, there was one question. Dennis had asked, so true, do we put it out there for them to see it? Dennis, I would assume that you're talking about mental health. Do we put our behaviors out there? But we can follow back up on that one. But definitely appreciate all of the responses. These all make so much sense, and it's exactly what we've been seeing on our end as well. So whenever we look at some of the barriers then, or that don't always show up, that are sometimes hidden in between, Dr. Tree, what would you say, how real is the fear of re-injury sometimes from a clinical perspective? And how would you say that would affect someone from the perspective of, are they going to report again? Are they going to report pain? Are they going to participate in recovery? What does that look like?
Yeah, and I think a lot of times the injured employee doesn't even realize they're experiencing this type of emotion or exhibiting this type of behavior. And then sometimes even a clinician may confuse this with, there's this bad word in injuries, worker injuries called malingering. So, this is something you can screen for and really help with interventions about helping an injured employee understand that they do have this potential fear of re-injury. But again, this is clinically real and measurable, and it probably attributes to about a third of what's driving a claim is just someone guarded about getting back into the same type of activities that injured them or that creates a lot of pain. And remember, we're talking also about a lot of the other mental health components that feed into pain and other factors like depression, et cetera. And so it really does, again, our injured employees are not medical professionals. And so they're not really understanding what's happening to them physically and mentally. And it really compounds what's happening. And so it's hard for them to comply to sometimes instructions or report pain appropriately. And so having a trusted partner that can kind of guide them through this process is really paramount for screening and for giving them next steps to expect in the process.
Of course, yeah. I noticed in the chat, I love this one from Brittany that was saying that it starts from leadership. Our company has done a fantastic job around mental health because our leaders believe that it's valuable to employees. And then Kendra came behind that to say, we talk about EAP resources regularly, or try at least, but they're relying on leadership to get to know their team so that they can look for those signs and behaviors, which, way to go, Kendra. That's exactly what you guys need to be doing. So applause to you there. Sarah, how would you say that when someone has a loss of their routine, or they feel like they're being isolated, how do you feel like that affects an employee's recovery?
That's a great question. And how many of us have heard or maybe even experienced that when we are going through something incredibly stressful in our lives, that we say, you know what, I just want to get back to work. Whatever's going on in my life, like I just feel good because I can come to work and do my job, and I know what to expect there, even when other things in your life are so out of sorts. But for an injured worker, that's not a possibility. They're hurt, they're stressed, and they no longer have, that routine or stability, that sense of purpose in their life. Mm-hmm. And so we're always, when we're in distress, looking for that stabilizing factor in our life. And now removing work from that's for most people 40 hours or more of their week that has now been significantly destabilized from that routine. And so now they're looking for other ways to find that comfort and stability. And oftentimes when you are more isolated because you're out of work, everyone else is working. So where's my support system? if you don't have the right support in place and the right resources, then you may lean into less healthy coping mechanisms, and all of this impacts the overall recovery trajectory.
Sarah, you bring up such a good point, and it brings me back to one of the stories that one of our clients had actually shared with me one time in conversation, which he had explained that he was up on one of the big wind turbines and had actually fallen and sustained pretty significant injuries. And he was talking about how he felt at home during that recovery period because no one was reaching out to him. In fact, the employees were told not to reach out to them because they were afraid that there could be some legal issues there that, to minimize the risk of the employee filing a lawsuit or something along those ways. But the employee that had been injured themselves came back and said, during that time, I was so depressed. I didn't want to be here anymore. And I felt like that I was all alone by myself and nobody was talking to me.
Unfortunately, the workers' comp and the work injury system is all about managing risk, right? Managing liability. And so sometimes we make decisions about how to handle injuries that are because we're concerned that it might increase that liability, just like you said. But there is so much research that shows that employers who stay in touch with their employees when they're out and who maintain that relationship and contact actually have much better return to work outcomes and recovery outcomes. So you're spot on with that.
Yeah, definitely. Debbie, I love what you put in here. You said, I'm on the employer side of things and we are in construction. So it's hard to see the signs a lot of times until something happens. I would love some ideas on how I can assist our employees that get injured and how to reassure them that we are here to help. I send personal cards with my business cards so that they have my number and that they can reach out to an adjuster. And she'd mentioned I handle all 45 branches across the United States, so I'm not in front of them, but was asking for any types of ideas that would be helpful. So I know that we'll get into those specific, we're going to go into some of those individual things that you can do with your individual employees further down the line, but really good point. And I have a feeling that you're not the only one that has those same feelings there. So when we look at kind of what happens when those aren't addressed, Dr. Cherry, I'll come to you and ask next, what starts happening when the fear, anxiety, some of this pain, deconditioning, all of those things, when they're not being addressed?
Yeah, so there's, when you look at like the statistical analysis of injuries or the epidemiology of injuries, a lot of injuries can be very effectively treated at first aid. And then there's this distribution that turns out to be kind of in this messy middle. And then there's obviously a tail of catastrophic claims or very extreme claims. But once a case starts getting into the week 4 to 6, if a worker's function isn't really on a good momentum to improve, so their biology is not responding like we would think there would be, it's probably not the main story anymore. It's not the physical injury. There's something else going on that's driving this timeline. And from everything that I've been learning over the last few years, where the studies have strong evidence, is there's a strong behavioral health component. And it can be, again, bidirectional. If someone has pre-existing mental health challenges like depression or anxiety, it can feed into chronic pain and different medication uses. But it can also just be as simple as you don't have mental health diagnoses, you just have concerns about the claim, like fear of re-injury, avoiding what caused the claim, etc. So again, there's kind of this biopsychosocial model where it's your physical side, but it's also your psychology and your social support that really drive a claim.
Absolutely. Kendra, I love what you said about we've seen depression due to disconnection from work and coworkers with our manufacturing team, and more so than what we're seeing with the office team, who may be more used to independent work environments. That makes so much sense because you have completely different environments. You may have an office environment where people can, you're seeing them face to face on a daily basis, whereas, if you're at home or something else, then you may feel a little bit more isolated. But Jennifer, this kind of leads into what I was going to ask you about, which was the communication components. And so I wanted to know what happens when communication starts breaking down and those injured workers, they are kind of left to fill in the gaps. They don't know what's going on. And so they just kind of come up with some answers and go-tos that they come up with themselves.
Yeah, this is where the situation gets really delicate. A lot of people don't realize, but the number 1 and number 2 risk factors for all mental illness are trauma, which an injury can be, something bad happens that overwhelms my capacity, and then isolation and loneliness. Having trauma, isolation, and loneliness, these are the number 1 and 2 risk factors for all mental illness development that impact us just as humans. I don't care any other factors. As a human being, they're there. The silence, the communication breakdown there. It's important to recognize because a lot of times, especially when we're at work and we have a mental health challenge going on, our behavioral health or our internal health doesn't announce itself. We don't usually experience, like something that's really blind or really bright, that signs and draws our attention. We experience a gap. We don't get a call back, right? Something does happen, but then we wait. We don't hear something. There's no updates on what's going on with the claim. Our answers about what's going to happen for me, and that silence neutralizes people. And then they start creating their own story and their worst version of the potential of the story. We start to make assumptions when we're in that place, like the people at work and my boss are going to think I'm faking it. I'm going to lose my job because of this. Nobody's on my side. I'm not hearing anything. And when one of these starts taking hold within our experience and the information isn't coming in to mitigate those, that a lot of times it just thinks, well, that's fixed, but I'm not feeling fixed in this moment. And it's very frustrating. That communication breakdown, it's the hinge. It comes before the duration of the situation that's happening. It comes before the cost is impacted, not after. We don't get follow through. We don't get visible results. Things stall. And we start to pull in other things, other people, other family, other parts of HR, and we start grasping at straws in order to get something that can be solid, that we can find trust in to move from. And that representation really enters when we feel unheard. You all have talked about a couple different times, that sense of belonging, purpose, meaning in what we're doing. Our jobs create that consistent space, and we'll talk about safety later. If we as an organization, as a leader, even as a teammate, if we can keep contact, a warm contact, doesn't mean you're, it's all kumbaya and I'm here for everything, but just that warm contact to help mitigate some of that fear that comes around. And there's a cadence to it that we don't just leave people hanging until we have a clear answer. That can really help with some of that fear. But to keep things concrete for people, every one of us wants something that's predictable, especially when other things feel chaotic or out of control or are really pulling us in different directions. And it's all right for us to reply back and say, you know what, I don't know yet what's happening, but I'm going to follow up. And I just wanted to check back in with you so that the quiet time doesn't last as long and we can really decrease or increase the opportunity for recovery, even while we're waiting for treatment supports or for that journey to evolve. So it's hugely important, the role that communication plays in here. And I want to stress, people are talking about what are things that I can do. None of this requires a clinician. You don't have to have a clinical background to do this part, to mitigate this communication breakdown that's there. As managers, as leaders, which, I've seen a lot in the chat saying, well, leaders do this or leaders are modeling, and that's fantastic. I love it when we have that leadership in our organizations, but honestly, all of us can be that leader. If we all train ourselves to be able to notice and be responsive, not reactive, the big thing about what the training does with mental health first aid, we all can play that role and get people to the help they need faster. And so that recovery process can really help and more naturally and in a rate that works best for that individual. It's huge.
Jennifer, that makes so much sense. Sarah, kudos to you. I was reading your comment just now, and Jennifer was talking about communication, and this just goes so perfectly with it. But you had mentioned my company also has a construction portion. Most of our guys really appreciate a follow-up phone call, just checking in around 3 to 7 days afterwards to show that you care and aren't just ignoring them. And she said we've had really good feedback from them and their wives. And just sending something like a small floral arrangement along the lines of thinking of you shows a more personal care and touch. So bravo. I commend you, Sarah, for what you guys are working on within your organization. That little bit of communication, just going the extra mile to reach out and just making sure that they know that they're not alone, they're not by themselves. It goes so far. I'm sure you would agree, Jennifer. Yeah, definitely. All right. Well, let's play the myth or reality game. So get your fingers ready to type in here. The first one that we're going to go through is, let's see, first one being myth or reality. Screening for behavioral health invites psych claims. Is that a myth, or do you think that that's reality? Screening for behavioral health invites psych claims. I think that this one makes so much sense because I think there's so many that fear that if you just bring up the topic of mental health, that all of a sudden you're putting ideas in someone's head, which, is absolutely incorrect. You guys are experts. Look at all these myths. Wow. Very well done. Very well done. You guys are killing it there. I couldn't have said it better. Jennifer, what would you say about this piece?
Yeah, definitely a myth. There is a huge misperception that if someone talks about mental health, that it's going to be like all of a sudden plant a seed in someone. It's already there. It is living with the individual. And by talking about it honestly, it decreases the risk of whatever challenge it is that they're facing or navigating for it to escalate into further crisis, because it takes away that fear that we mentioned before. And it just gives the opportunity to be like, oh, okay, maybe somebody will hear me. Maybe there's another option or any option that I can utilize to help take the now of the experience that usually doesn't feel so good into what could be next. It could be healthier, more productive, better for me, whatever that looks like, depending upon the situation. So it's incredibly important for us to talk about. It's incredibly important for us to fine tune our radars so that we notice earlier instead of just waiting for the claim to happen. If we notice things earlier, then we can do that prevention and be able to be more responsive versus just putting the fire out when the bad thing goes down. And that's on each one of us to expand those skills. And that is something we can all foster and develop.
Absolutely. Dr. Shree, what would you say, how can employers screen and kind of respond appropriately without stepping into clinical territory?
Right. And so many times in even a clinical practice, you can do a screening without diagnosing. And what we're talking about here, screening for some of these behavioral health factors, is really prognostic and not diagnostic. So it's telling us who may be at higher risk for a slow claim, for an inefficient claim, for someone who's at higher risk for not following kind of just a purely biological recovery where you do have the mental health aspect. And so it doesn't diagnose anyone with anything. It's just screening them to see if they could, really benefit from additional support throughout the claim. And so, for instance, when you get your blood pressure checked at the doctor's office, you're not immediately going to be diagnosed with high blood pressure or heart disease or anything like that. It's really just kind of seeing, early risk factors.
Agree. Teddy, I love what you said about, we're talking about that you have it set up with where their safety team looks for answers, identifies some root cause, look for corrective actions, things like that. But all the stuff in there is an effort to learn and identify some of those gaps. So excellent there. Kudos to you. Let's move on to the next one here, the next myth or reality. And so the next assumption would be if we don't need to ask because we thought someone was struggling, but would we? You know, we think that we would know those signs, but would we really know if somebody was struggling? So would you say that that's a myth or reality? We know if someone was struggling. Darren, what's your thoughts here while we're waiting for some of this to come in?
I think we overestimate our ability to know most of what other people are feeling, much less ourselves. I was listening to one of the founders and experts on emotional intelligence, and he said we do a pretty poor job of calling our own feelings out, much less knowing anybody else's. So I think this is probably a myth, but I think most of you are agreeing.
It looks like it. Yes, I haven't seen any of those that say that it's a reality. Everyone is on board saying that that's a myth. So well done for you guys. You're exactly right. And you know, if these signs aren't always obvious, the next mistake is treating behavioral health like it's something that's completely different as injury management. So that brings us to our next one, which is that we would know if someone were struggling. So we think that we would always know, you know, are the warning signs always obvious? What tends to go unnoticed? And why might an employee be hesitant to speak up? So we can split those up. And Sarah, I'll come to you first and let you maybe take the first one. Why have behavioral health and injury management traditionally been treated so differently? And what does it cost when those two things are disconnected?
Well, I think that mental health and behavioral health are seen as this kind of very nebulous thing, right? If someone sprains an ankle, we know exactly how to treat that. And we generally know the duration of that treatment. When we talk about mental health, and especially when we're talking work-related or not work-related, there's a lot more gray area. And so I think there's often this desire to treat them separately because one is much more tangible. You can see it on an x-ray or a scan, whereas with mental health, it requires a lot more nuance. And so let's just kind of exclude that more complex one and focus on the simplistic.
Yeah. Dr. Cherry, could you think of maybe an example that you could share with the group about when you had something that was a physical claim that appeared to be healing, but then all of a sudden it felt like it stalled out because of a behavioral barrier? Can you think of a scenario that you've seen in your practice at this point of how that had occurred?
Let me give that some thought. You know, I think that a lot of the times, one of the most common types of claim is musculoskeletal and then low back injuries. And many times people have actually chronic low back pain, and then they have an acute event that kind of pushes them over the edge. And over time, people get sensitized to that. And it's really a psychological sensitization as well as the biological injury. So many times low back injuries should recover in, 2 to 4 weeks. So when I see people that are going beyond that, it really is time to key in on looking at what else is driving this besides, their x-rays are normal, their exams are improving, but their return to work expectations are quite distant still. And so the psychological aspect of it, you can reassure that they're going to not only recover physically, but there's ways to strengthen and make the person more work hardened or more resilient. And so those type of reassurances go a long way. And I think sometimes employees are fearful that they can never return to work, right? And so they're just bogged down in this claim until they get clarity about if they're ever going to be good to go.
Absolutely. All right, here's the next one. This one's one that we see a lot. So the question here is, behavioral health is separate from injury management. That actually wasn't the one I wanted to look at. I wanted to look at this one that right here that talks about it being separate. So with those two things being separate there, what some people talk about actually the EAP and some of the things that are associated with that. They feel like that just because they have an EAP that they're covered. Sarah, why is it that organizations can have a strong EAP available, but then yet still just such a small percentage of employees are actually utilizing that?
Yeah, well, unfortunately, most of the mental health and healthcare system is reactive as opposed to proactive, and EAPs are no different. It is there if you call it when you need it, but most employees don't even know that their company has an EAP, or they don't even know what an EAP is. And so those are two critical barriers. If we don't even know that this exists, how do we ever access it? But also it requires a high level of emotional intelligence and self-awareness to recognize that something's going on and that it's at a point where I need some help. So only for most EAPs, it's about 1% to 3% of employees who are actually using the program that's available to them because they don't know about it. They may not know that they need it. Even if they know that they need it, they don't know how to get to it. And so there's just this huge gap between the need and the support that's available.
Yeah. And would you say that for that specific reason, that's why, even within our own organization that we've implemented, behavioral health programs where we screen for some of those things, because you can't rely necessarily on just saying, putting a poster up that says, hey, this is the EAP number, and trust that people are going to call.
Oh, absolutely. I used to do a lot of crisis management, crisis response work for companies. So I'd be the person going out on site in critical incident, maybe a fatality, even mass casualty events. And so there were times where we would meet with hundreds of people after an incident that had occurred. And we are providing that immediate support, talking up the employee assistance program. Here's a handout, here's the phone number, how you call. And I very quickly learned that you could give that number to 100 people and maybe one will call it. Maybe. And those are people who are in a crisis, who are really going through something serious. And so even when the need is that great, that significant, people aren't calling it. The difference, though, when I shifted was, hey, let me take a few minutes. Can I help you make that phone call right now, get you on the line? And so when you take those steps to say, hey, let's do some screening, let's take a look at what's actually going on, help increase that self-awareness when there is the need, and also make that connection to the right resources, makes a significant difference.
And I would think too that whenever you're maybe going through something or you're in a crisis, that you as a person that's experiencing that at that time, that it would be difficult necessarily to raise your hand or take the action to go ahead and pick up the phone and call that number or make an appointment. Do you see that pretty commonly, Sarah?
Oh, of course. There's so much stigma around mental health, even still. And so if you are concerned that your mental health is not in a great state right now, whether that's because of just personal dynamics and stress, or you're concerned that you might actually have a mental health condition, if you don't already know that EAP number, have that resource, and it's, well, hey, I have to go ask my supervisor or contact HR and ask for that. Well, now somebody knows that there's something going on with me. And are they going to question my mental health, my fitness for duty? Is this going to impact my reputation at work? And so there's also that barrier of, I just don't want my company knowing what's going on with me because I don't want anything to risk my employment.
Absolutely. Jennifer, why do you feel like that there's that stigma there, or there's the belief that, it's not bad enough yet, and so therefore people don't reach out for help?
We oftentimes struggle with admitting any sense of weakness or challenge. We know, or we worry that it's going to impact how we're seen within the workplace. And there's a big difference between having a resource, which is wonderful, and EAPs are amazing. We need to have that. But having a resource is really different than having a response. A phone number, an email address, a link, a Slack channel, that's a door. But that individual still has to decide whether or not they feel that they're sick enough, if they're ready enough to walk through it and actually take advantage of the resources there. On top of it, the stigma of not really understanding it. And then we get overwhelmed. We go into all these amazing resources we have, but in the moment of crisis, you go into the brain science, our amygdala shuts down the prefrontal cortex where we decide things and memory and all that. We don't even know what to do. And then we get overwhelmed, and then we don't utilize the services. That then builds on the stigma of saying, oh, it's not bad enough yet. Or what if somebody sees it? Or I don't really know what to do, so I'm just going to do nothing because I'll be fine. It'll get better. I'm just going to push through, right? We all have that warrior mentality. We just push through and make things happen. And training for recognizing, to notice these quiet things, to battle the stigma that is present. And depending upon your industry, I mean, I've seen a lot of comments here about construction and manufacturing, what have you. We have some industries that have even higher stigmas just because of the nature of the work that they do and the culture that is among this industry. And in mental health first aid, we really build on the opposite of the assumption of an EAP. We don't train people just to wait for a request. We train people to notice the changes that are happening, and then to approach. It's the same reason why we teach people how to do physical first aid, right? CPR and all of that. We don't hand someone a pamphlet and hope you get treated, right? The action plan we teach in mental health first aid is about approaching. It's about listening without judgment. Where's the reassurance and information, and where are the appropriate supports, whether professional or not, depending upon someone else. So the EAP really isn't the plan to be responsive, but it is a step on that path. What's important for us is to remember, and I think Sarah mentioned this, is that warm handoff of saying, hey, you know what, here is the number. Concretely, though, can I sit with you and help you make that call? Just in case, right? Or to help you. It's about noticing at every level of the organization for all of us, not just our leadership, not just our HR team, for us to notice from the levels to say, hey, I'm noticing this, and starting that conversation so that the stigmas can go down, the fear can go down, and to make it part of our normal every day, so that people know what's there before they actually need it. And they know that they can reach out before they actually need it when everything gets so overwhelming and complex. So I honestly think that our job in this, and those of us here just kind of listening and learning, it's just to notice. How can we better, again, get that radar going so that we can notice, we ask the right questions, and then based on what we get from those questions, where can we connect them to the places that are appropriate with all the resources that are available for someone? And that's big. We have the fears too, the stigma about what does HR do with this information? And we can talk about the confidentiality over and over and over and over again, but there's still that stigma and that fear that, oh no, if somebody knows, what's going to happen? I hear utilization is all that we count, but we're also people. Where else happens, or what else can happen in that? So it's really complicated, but there's so many concrete things that we can do. Just some of the things you might already be doing, but if we can put it in a framework to say, have I done all that I can? We can mitigate that stigma, decrease the risk of escalation, and really get people the help that they need in more comprehensive ways and quicker.
Absolutely. You know, and this is where kind of the concept of early intervention, we talk about that from a physical standpoint. I'm sure you guys have heard us talk about that in each of these webinars about early intervention from a physical perspective, but that also exists for a mental health perspective as well. And so, Jennifer, I was actually going to ask you, what does a simple, appropriate check-in, what does that kind of sound like? Talk us through what it is, what it isn't, how you would go about that. Give our audience some insight. I know that they were having some questions early on, so this will be very valuable.
Yeah, before you even check in though, Holly, I got to come back to where are you as the individual in this noticing. In mental health first aid, we teach about, it's about identifying recognition that you have on here. It's about attempting to understand. That's where the conversation comes in. And then how do we respond to support? How do we make those connections? It is our role with the connection is to think about we're the bridge. We're that bridge of help. We're not the help itself, and we don't need to be. I can tell you how many people have come into these trainings to be like, oh my gosh, this is one more thing on my to-do list or my job responsibilities. And really it's about not even a mental health first aid speak, but how can I be a better human to the human that I'm noticing these challenges happening with? So being that bridge to help, lowering the bar of stress to say, I'm not qualified, I don't know what to do, but knowing, hey, but here's the resources, and this could be a resource that would help you. giving the right level of support, and really giving the opportunity for them to feel empowered to step into that conversation. How do we do that in that check-in? It can be as simple as some of the things I've seen in the conversation. Maybe it's that text message like, hey, talked to you yesterday. How's today going? Maybe it's that note and a card, like, haven't talked to you for a while. I know you're off, but don't want to cross the boundaries of all the, requirements of someone's on medical leave. But the human in me is concerned about you. And I just want you to know that you're still on my mind. There's conversation, we care about what's happening to you. And is there anything you need at this point? So the things that you would do in your basic everyday life are things that we can do in this role, just still being conscious of our professional boundaries. But please remembering that we're the bridge between. We don't have to be the help. Leaders, we have a terrible issue with problem solving. You're great at it. It got you into your roles, and please keep doing it. But when it comes to mental health and well-being, you're not the fix. There's professionals that are out there. We just want to guide people in the right direction and be that conduit of care, so that their now doesn't have to stay as cumbersome or difficult as what's potential in the next moments.
100%. Sarah, what would you say that makes a good handoff? And before I even get to that, Jennifer, just revisiting that, I feel like that whenever we took the mental health first aid course that you guys had done the instruction for, that was one of the most valuable courses that I've ever taken in my entire career. So if you have not been through one of those types of courses, I would highly recommend that you look into it for yourself and you look into it for your supervisors, your employees, et cetera, because it makes so much sense and it takes away the fear of being the one to approach them. It gives you a little bit more confidence and what it is that you can ask about. So there, I appreciate what you're saying about the mental health first aid. It goes a long way. But Sarah, talk to us about that handoff. What's different about just giving somebody a phone number and telling them to go to EAP versus what we would do from a mental health first aid perspective?
Well, I think, first of all, for any of us, when you're going through something, when you're under a lot of stress, and especially if it's a work injury that we're talking about here, you have medical appointments, there's paperwork, there's an adjuster, a case manager, possibly your supervisor, HR, right? There's so many people to be in contact with and so many things to be done. And so if somebody hands you a phone number and says, you can call this if you need it, okay, well, that goes into the stack of papers and things to do, and it falls to the bottom of the priority list. So getting somebody to the right resource means making sure that is going to be effective, right? Not just handing the phone number. So that's why I think that it is so important to sit down and help someone make that phone call whenever we can. Or like if you're a supervisor, an employer, respecting that confidentiality and that privacy, it might be, hey, let me give you a little bit of time while you're still here to step into an office and make a phone call. Or let me connect and make sure that you've gotten all the resources that you need. Is there anything else I can help connect you to? But resources for mental health aren't always treatment, right? As we talked about, mental and behavioral health aren't just diagnosable conditions. It can be anything in that first aid level. I am stressed. I'm concerned about my finances because I'm going to be off of work and I'm not making my full pay. I am alone now for being out of work, right? So it can be all of these other things that are impacting someone's overall mental well-being. So when I talk to people, it might be, how did you sleep after the incident? Because you've probably got all of this adrenaline running through you because this was a, really high stress situation. And that can impact your sleep. It can impact how you're feeling through the day, your general mood. Well, let me help get you some resources on how to improve your sleep and how to manage some of this stress in the short term. If we can address it today, the day after something has happened, or in the few days after an incident has happened, as opposed to a month, 6 months, or even years down the road, sometimes in some of these cases, the level of response or support looks very different. We can tackle something with just maybe even a handout or a short conversation, right, if we address it in real time. But if we're talking where, as Jennifer alluded to earlier, where things have started to kind of compound or grow over time, Well, now we are into this is treatment, and it might be a longer term treatment because we have let things decline without being addressed.
Absolutely. Jennifer, whenever we talk about the signs that are routinely missed, and we have many of those that are listed right there on your screen that you can see, but what would you say that gets missed most frequently and why?
Oh my goodness, we could spend all kinds of time on this, but honestly, I want to push back slightly on this premise because it really isn't about just picking one. We get into dangerous territory and we just say, oh, well, they're frustrated. Really? There's probably more to it. Mental health first aid, we don't teach a list to memorize of signs and symptoms that would draw our attention, but we do teach about how to notice what has changed or shifted from that person's baseline. Not did they meet the criteria, check, 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 check down the line. The signal isn't the behavior that drew our attention, it's the change in the behavior that's happening. So there's kind of like a pattern, like rules of thumb is to watch for the duration or the diff, the duration, the intensity, and the frequency, or the impact and the frequency. Is it lasting more than a couple weeks? Is it happening more often? Is it showing up in more than one column on this list that's on your slide here? Withdrawal is missed a lot of times. And that change and someone is communicating, it's not the small things, it's the small things that accumulate into the big thing there. So one thing I want to stress as well is that a lot of times we mislabel what we see. And what we see is sometimes we label as maybe a performance issue and don't look at what else is underlying or bringing a person to the place where it's drawing our attention. Frustration is a big one. If I had to pick one, I'd probably say frustration, because it's not only the most common, we're at work, for goodness sakes, right? But because it's the one we typically punish instead of explore. We see someone's attitude is, the irritability is read as an attitude. Short answers in a conversation are read as disrespect, where the distress is going to show up maybe as anger, and we think we need to manage that. So or we miss an appointment, we show up late, we're not compliant with things. So we've got to be really, really careful when we start thinking about the signs and when we notice. But the moment we notice, it's about coming in with a plan. It's just like we teach that algae action plan, that 5-step. How do we approach? Who's around? Do we need to be private? What's happening? We're not diagnosing. We just want to get the person in a safe place where we can step into the conversation. And that can be simple, Holly, like saying something like, hey, I've noticed. Maybe you've missed the last 2 safety checks at the start of the day. It's not like you. What's going on? So noticing the pattern, speaking to the pattern that's concrete and identifiable without assumptions and judgment on to what's going on. This is huge. Take the judgment out of it. Take out your problem solving to fix it, and give the opportunity to say, hey, here's some reassurance. You're not alone, or whatever's going on. Here's some information. Here's what's possible. This can take 3 minutes. It's not clinical. You don't have to be a therapist to do this. You're just, again, a caring and compassionate human that noticed something different than is typical and now is being responsive to guide them in the next rail. All right. So don't make the assessment. You don't have to assess, but open the door. But don't just open the door and say, good luck, hope it works for you. Stay in the room. Yeah. Stay in the room and really look at what's there, not to fix, but to notice and what's possible, what's new for that person, and where can we guide them.
Excellent. I couldn't have said it. Wow, Jennifer, I think, I don't even know that we could even repeat or paraphrase that. You said it so well, but I couldn't agree more. Dara, I'm going to come to you next, because whenever we're talking about psychological safety and how it is that you would encourage that within your own work environment. And what I'd like to ask you is, can an organization have excellent programs, maybe some resources, but still they're undermined if employees don't feel like that they can speak up?
Yeah, absolutely. And I keep coming back to lately, you get what you incent. And if you incent certain behaviors in organizations, you're actually going to discourage people having these conversations and feeling safe. So the example I always use or have used lately is if you highlight and incent 0 injuries or no injury reporting, what you end up doing is incenting people to not feel safe in reporting or reporting near misses. So it's the same things. If you build systemic approaches to these things, using psychological safety, using mental health first aid as a framework, it's not that we all have to be experts at this, but not doing anything is really not the right approach. But I also, Dr. Cherry and I were presenting at a very industrial site. It was a manufacturing site. And we heard an employee talk about this from her perspective. And she had dealt with some of her own challenges. And she said now when she sees one of her colleagues struggling, she's a big advocate for escorting them. And I don't think she was trained in mental health first aid, but she escorts them right into the support process. But she was very visibly supportive just in general about having these conversations. And it was really cool to see. So I don't think we've seen sweeping changes yet, but I do hear more and more of those moments happening in the workplace, which is wonderful to see because she felt safe enough to say that out loud.
Absolutely. Sarah, I know that we're at time here, but I wanted to make for sure that we can wrap up here in talking about the payoff, what makes sense, why early intervention matters. So maybe if you can just talk to us about what would make the biggest difference then in behavioral outcomes for employers. Do they necessarily have to implement some huge program, or is this something that you could take back to your workplace and start implementing now within your organization?
You can absolutely start implementing this now. And again, even if you're not in a leadership position, just by showing up as a compassionate, caring human being, checking in with colleagues, checking in with your employees, talking to them about just how they're doing, getting to know them as individuals. If you know what's going on and what, a little bit more about someone outside of work, then it's much easier to identify when things have shifted, that behavioral change that Jennifer was talking about. So absolutely, this is something where you can start right now. You can help by helping make sure that employees know about that employee assistance program and encouraging them, like I mentioned before, hey, take a few minutes and call right now if something's going on, or reaching out maybe to your HR, or reaching out if you work with us, reach out to us about how we can help support your employees. So it isn't something that has to take a whole big shift. Now, if you have the resources to build out a program around employee mental health and well-being, absolutely, I fully support that, and that's wonderful, but I know that not everyone has that available. So you can absolutely start small.
Awesome. Dara, Sarah, Jennifer, Dr. Cherry, we appreciate you joining us. Your insight has been extremely helpful. I know that the audience has appreciated that as well. If you guys haven't already, make sure that you click on that RSVP button to sign up for next month's webinar event, which is going to be on fatigue. And we look forward to seeing you in September. Have a great day.
Thanks, everybody.